So hello, good morning, good afternoon and good evening to all our speakers, chairs and the wonderful audiences in different parts of the world. Welcome to ACNS webinars. The speaker for the first session of today is our honorable guest from Japan, Dr. Jun Tanabe. Dr. Tanabe is an associate professor in the Department of Neurosurgery at the Fujita Health University, Bantane Hospital, Nagoya, Japan. He is a board certified member of the Japanese Neurosurgical Society as well as the Japanese Society of Neuroendovascular Therapy. His clinical interests are focused upon the management of cerebrovascular diseases, especially surgical clipping, endovascular therapy, bypass surgery and subarachnoid hemorrhage. He is an authored author with several publications in various peer-reviewed journals, and we are extremely grateful to him for accepting our invitation to be a speaker at our webinars. And today he will be talking about web treatment across all subtypes of wide neck aneurysms, current limitations and challenges. The speaker for the second session of today is our honorable guest from China, Professor Shi Huaizhang. He is a director in the Department of Neurosurgery at the first affiliated hospital of Harbin Medical University, Harbin, China. He is the deputy chairman of the Chinese Federation of Interventional Clinical Neurosciences, deputy leader of the Cerebrovascular Disease Group, Chinese Neurosurgical Society, and the standing commissioner of the Chinese Congress of Neurological Surgeons. His clinical interests are focused mainly upon the management of cerebrovascular disorders, and he is a noted author as well as editor of the Chinese Journal of Cerebrovascular Diseases and Chinese Journal of Interventional Radiology. We are extremely honored to have him today with us, and today he will be talking about microsurgical treatment of cerebral aneurysms in the intervention era. The chair for the first session of today is our world-renowned cerebrovascular surgeon from Canada, Prof. Ashish Kumar. Dr. Ashish is an assistant professor in the Center for Cerebrovascular and Endovascular Neurosurgery at the Sunnybrook Health Sciences Center, University of Toronto, Ontario, Canada. He was a past fellow at the Fujita Health University as well as the University of Toronto, Canada. He is the fellowship director of the Advanced Microneurosurgery at his institution and is also the vice chair of the Inclusion and Diversity Division of Neurosurgery. He is a hybrid neurosurgeon who specializes in the management of aneurysms and other cerebrovascular diseases. He is a noted author with several publications in various peer-reviewed journals, and we are extremely honored and grateful to him for accepting our invitation to chair the first session of today's webinar. The chair for the second session of today is our honorable faculty from Japan, Professor Hirohito Kimura. Prof. Kimura is a consultant neurosurgeon in the Department of Neurosurgery at the Kobe University School of Medicine, Kobe, Japan. His clinical interests are focused upon cerebrovascular neurosurgery, especially bypass and aneurysms. He is an integral part of the ACNS delegation in various countries over the years for workshops and conferences, and we are extremely grateful to him for accepting our invitation to chair the second session of today's webinar. On behalf of the Education Committee of the ACNS and the President, Prof. Yoko Kato, I would like to welcome both the speakers, chairs, and the wonderful audiences to this online platform of ACNS webinars. A very warm welcome to our colleagues in China, and we are extremely grateful to Professor Shubin for broadcasting this webinar on the WeChat channel. Dr. Liu Bun Seng from Malaysia is my co-host for today. With that introduction, I would like to hand over this online podium to our first chair, Prof. Ashish Kumar. Prof. Ashish.
Thank you. Thank you, Raja, for the great invitation. Good morning, good afternoon, everyone. We are in the era of cerebrovascular surgery where every day we are looking into different kind of neurointerventional techniques which have come into the cerebrovascular world. I think with the recent introduction of the web devices, cerebrovascular surgeries are probably it is being quite often used even here for ruptured aneurysms, and slowly and steadily we are moving away from the coils and the stents in acute ruptured situation to the endosaccular devices, and we are also getting used to it. So we'd like to really know about its various indications in ruptured and unruptured aneurysms from Professor Tanabe. So I would like to invite you to please share your wisdom with all of us. Over to you.
Thank you for the introduction. Thank you for the opportunity giving me the opportunity to present here. So I'm Jun Tanabe. I'm working in Fujita Health University, Bantane Hospital, and there's Professor Yoko Kato. So I'm going to talk about the web treatment for all subtypes of wide neck bifurcation aneurysm and about the current limitation and the challenges. The web was introduced in Japan more than 10 years later in Western countries. In Japan, however, the indication was expanded to all bifurcation aneurysm. And since then, we have used the web first-line strategy for eligible patients. This is our web first-line strategy. First, we check whether web treatment is possible based on several factors. If web is not suitable, we then consider stent-assist collateralization, and if needed, directed surgery. And under this first-line strategy, we have performed 274 web cases so far. First-line strategy, we have performed 274 web cases so far. This number, which is the largest number in Japan. In this talk, I will share the key tactics that helped us establish this web first-line strategy. Does not work. Sorry. I will explain the tactics to achieve the web first-line strategy, focusing on 3 points: aneurysm location, off-axis aneurysm, and the aneurysm shape. First, what kind of aneurysm are suitable for the web treatment? In Western countries, only 4 locations of terminal bifurcation aneurysm were on label for web. As aneurysm were considered atypical locations. In Japan, non-terminal bifurcation aneurysms such as ICP-COM, IC anterior corridor artery, are also indicated, in addition to terminal type bifurcation aneurysm. Here are the clinical results of web for the expanded indication covering all bifurcation aneurysm in Japan, which we previously reported. The aneurysm location, most aneurysm location was the ACOM, followed by MCA, and the third group was the ICP-COM as an atypical location. Morbidity and mortality were the 0.8%. The complete occlusion rate was 68.8%, and the adequate occlusion rate was 90.6%. So the safety and efficacy outcome were acceptable. This slide is a summary of the clinical result. And even with the expanded indication we reported, most aneurysms could be treated effectively with the web, and the outcome were similar to those in the WebWit and WebCast studies. In short summary, if the web can be deployed, all bifurcation aneurysms with side branches are candidate. During this period with the web first-line strategy, 92.7% of wide neck bifurcation aneurysms were treated with the web. We think that aneurysms that are not suitable from the beginning are those wider than 10 millimeter, and extremely wide neck aneurysm with a shallow shape, like a Mount Fuji. It is an infeasible aneurysm for web. Next, I will talk about off-axis aneurysm. In general, it is difficult to deploy the web in off-axis aneurysm. So, how much parent aneurysm axis deviation still allows web deployment? What is the standard web deployment technique? The deployment technique has been described in a review article as an expert opinion, but there is no single standard method for web deployment. One technique is the ordinary unceasing method. We navigate the microcatheter to the deep fundus of the aneurysm and deploy the web only by unceasing the catheter. We use the only unceasing maneuver. So web was fully deployed. And this technique is generally useful, but it cannot be applied to all aneurysms. For off-axis aneurysm, where the angle between the parental artery and the aneurysm is 45 degree or more, it is difficult to deploy the web using the ordinary Aneurysm method because the microcatheter cannot be navigated into the deep fundus of the aneurysm. We experienced the most common aneurysm is the ICPC with the axis deviation, and that is the king of the axis deviation. Here, I show the stage of web deployment. In the initial deployment phase, called the seed and the sprout phase, the device is very stiff, like a spear. In the middle phase, which we call the flower bud shape, the tip of the device becomes softer and we can push the system to adjust the web position. In the final flower phase, the device tip is more horizontal, and it becomes difficult to change its position. This video shows the web deployment phase. We should recognize each phase during the procedure. This is the seed, now flower bud, and now it's the flower and the fully deploy. We should recognize each phase during the procedure. We introduced the flower technique, which we previously reported. This technique was developed to deploy the web in off-axis aneurysms such as ICP-COM aneurysms. The key point is to use the flower bud shape. Flower bud shape is here. We navigate the catheter to the neck and deploy the web by only unceasing until it forms a flower bud shape at the neck or in the parent artery. Once the flower bud shape is created, we gently push the web into the aneurysm to the proper position and then complete the deployment. We compared the flower bud technique with the ordinary unceasing technique. All ICP-COM aneurysms were treated with the flower bud technique, so flower bud technique is an essential technique for ICPC aneurysm. The parental artery aneurysm angle was more acute in the flower bud group. And treatment results were similar between the two techniques, but one intraoperative rupture occurred with the ordinary unceasing method. The flower bud technique is likely safer, and we now use it all web cases. This slide shows the catheter system for the flower bud technique. We use the mandatory intermediate catheter because this technique needs the one-to-one push-pull responsiveness. Depending on whether we use adjunctive technique or not, we choose different catheter systems. One of the most important tips is to shape the microcatheter properly. This video shows an ICP-COM aneurysm treated with the flower bud technique. We navigated a J-shaped microcatheter into the aneurysm. So the web was loaded into the catheter tip. So now loaded. So we created the flower bud shape by only unceasing at the neck. we use the only unceasing maneuver at this phase. Now we created the robot shape. After that, we moved the web into the best position and then complete the deployment. We slightly pushed the system and fully deployed. Three months after treatment, DSA showed the complete occlusion of the aneurysm. This video shows an isotope aneurysm and highlights the importance of proper microcatheter shaping. First, we made the S-shaped microcatheter. So we navigate into the aneurysm. So the web is loaded. First, an S-shaped microcatheter protruded into the parent artery when we insist to merge. So we pulled back the web, reshaped the microcatheter, and repositioned it correctly into the aneurysm. After that, using the Flava technique, we were able to deploy the web successfully. So it is very important to shape properly, like these cases. This is the final view. 3 months after treatment, DSL also showed complete occlusion for this aneurysm. This video shows an IC cable aneurysm concomitant to the AVM. A spiral-shaped microcatheter was navigated into the aneurysm. Web was loaded. So as you can see in this video, the key point I want to emphasize is to insist the web slowly, very slowly at the neck or in a parent artery until the robot shape. We perform the very slowly insist the web shape was the now seed or sprout. Keep persisting. So now you can see the robot shape. After that, we can perform the various maneuver to place the web in the best position. Now the web was fully deployed. This is the final view. So assisted bearing technique are also useful. They help to stabilize the catheter and to create the neckline or neck. Pushing the web with the balloon after deployment carries a high risk, and it's not recommended. This video showed the usefulness of an assist balloon. The aneurysm was also ICK, so web was loaded, but the catheter system was protruded into the parent artery to unceasing. So by inflating the balloon, we create a wall distal to the neck, which can help reposition the web into the aneurysm. Sometimes balloon assist is very helpful to position the web system. And we check the neckline and with the balloon. So this is the short summary. There is no strict limit for the degree of off-axis deviation. Stable intra-aneurysmal catheter positioning achieved by proper shaping is essential. Assist balloons can be useful in selected cases. Next, I will talk about aneurysm shape, focusing on sizing and indication for irregular aneurysm. Conventional web sizing used the ±1 rule. The web width is 1 mm larger than the aneurysm width. The web height is 1 or 2 mm less than aneurysm height. Based on this rule, a sizing chart is provided by the manufacturer. However, for irregular aneurysm, this rule cannot always be useful. To solve this problem, we introduce a volume-based parameter, the I-web ratio, which is I-web ratio is the web volume divided by aneurysm volume. Here, the aneurysm volume means the estimated volume of the intended web deployment site. So we excluded this part is the volume. If the I-web ratio is between 0.9 to 1.16, we can choose an optimal web with a high chance of success. Our flowchart is very simple. First, select the width by adding 1 or 2 mm to the aneurysm width. Next, choose a web size that gives an I-web ratio in this range. The web height is then automatically determined. This is the This is the size chart we used, which includes the volume of each web size, like this. We use this web size chart. I will now show an example of optimal size selection using our flowchart in a real case. This is a left MCA aneurysm planned for web treatment. We estimated the shape where the web would be placed, excluding the tip of the aneurysm excluding the tip of the aneurysm. Based on this space, the average width was 5.1 mm. So in the first step, we select the width, select the web with 6 mm width. Here, the aneurysm volume was 58, so we choose the web 6/3, which gave an I-web ratio of 1.0. However, DSA showed that the web 6/3 was slightly undersized. and therefore we exchanged it for web 6x4. 3 months after treatment, the aneurysm was completely occluded. The reason for the initial sizing failure was that we could not correctly estimate the volume where the web would be placed. If we had estimated the aneurysm volume as shown on the right side, we could have selected the optimal web from the beginning. This is why it is essential to have this image in mind before the procedure. Let's review web treatment again. How do you deploy the web? This is an ACOM aneurysm with an irregular, hat-like shape. How would you deploy the web in this case? We estimated that the web would be placed mainly in the lower zec. Based on this, width and volume on this space, we selected the SL5 and deployed it planned. We put the web like this, so next sealing is good. So 3 months after treatment, complete occlusion was achieved. The next case is also an ACOM aneurysm, but with an irregular SOX-like shape. How would you deploy the web in this case? We estimated that the web would not reach the tip of the aneurysm and that it would mainly fill the base of the aneurysm. So we navigate the microcatheter like this. So we put the web this space. So based on the width and the volume of this space, we selected the web SL 8x4. So we put the web like cork the neck. 3 months after treatment, complete occlusion was achieved. As these cases show, we should practice predicting the optimal web position for each aneurysm. However, predicting how the web will finally sit requires a certain amount of experience. To help operators who have less experience with the web, AI simulation may be useful. We are trying to use this software provided by this that is Sim and Size produced by Sim and Cure to estimate the web deployment and the optimal sizing. We can see the expected web position and the size preoperatively, which may help with size selection. We use this software. We treat the MCA large aneurysm, so we can see the good position of the web treatment. We must remember that the web cannot be useful for all aneurysm. Shallow aneurysm, very irregular shape, and other factor can make web deployment difficult. So please remember, don't try to treat everything with the web. This is a case of ACOM aneurysm with shallow and multilobular shape, like a Napoleon's hat, where we first attempted web treatment. We initially microcatheter into the upper lobule and front to place the web there. This video shows the case. We navigated the microcatheter into the upper lobule as planned. However, when the web was loaded at the catheter tip, the catheter straightened toward the lower lobule. After that, the web could not be distributed into the upper lobule. So finally, we treated this aneurysm with a flow diverter and adjunctive coiling instead of the web. In summary, procedural imaging to predict how the web will be inserted is crucial. However, shallow-based multilobular aneurysm can be very difficult for web placement, so proper case selection is essential. This is another web attempted case. This aneurysm shape was also very shallow and multilobular. We treated this aneurysm with stent-assist coital embolization. In conclusion, since introducing the web in 2021, we have developed and refined our web first-line strategy and related tactics. Understanding the limitation of the web is important, but most wide neck bifurcation aneurysm can be effectively treated with the web. I hope this presentation will be helpful for your daily practice starting tomorrow. Thank you very much for your attention.
Thank you so much, Professor Tanabe. This was a masterclass of web applications. I know there are a lot of young neurosurgeons also watching this webinar. So I wanted to start with some basics in terms of the indications for web treatment. So as I said before, there are a lot of indications and there are a lot of tools to treat in endovascular world. Which cases, I know you have shown the cases which were difficult and should not be treated with web, but cases where you can do either the coiling or the clipping or stent assisted coiling, how do you decide which device to choose, for example? Let's start with, for example, MC aneurysms, right? So usually you would have a tendency to treat them as with clipping, and that's how actually we also practice. But yes, there are some non-surgical colleagues of ours. They have no option, so they try to treat it with web. But as a neurosurgeon, how do you decide between clipping an MC aneurysm versus a web device placement?
So, thank you for your question. Firstly, we think that we can, if the aneurysm can be treated by web. So if the aneurysm cannot be treated with the web, secondary, so we think with the stent assist coil embolization. So if not, we choose the surgical clipping. This is our web first line strategy. So, for example, MC aneurysm, almost all MC, so many MC aneurysm can be treated by web, but as we show, the very shallow and very wide neck MC aneurysm cannot be treated by web. So, and very small size and multi-lobular, we can choose the direct surgery and as clipping.
Okay. And in terms of the only criticism which web has faced in over the years is the complete occlusion rates are pretty low. So if you can see, even in your data, it was, I think, around 68% complete occlusion. So what do you think about that when you're thinking about something like a flow diverter or something like a standard coiling?
I think complete occlusion is about 70%, but I think it is acceptable, and adequate occlusion, complete occlusion and neck remnant reached about 90%. So adequate occlusion, I think it's a stable stable and of occlusion. I mean that there is a very low risk of rupture and retreatment. So that is why the web treatment is acceptable.
Okay. Do you prepare now coming to the you already shown like a lot of patients who where web should not be deployed because all of them, if you see, was in MCA territory, like atypical aneurysms with small blebs and different angulations, multilobules. So that was an example where probably you can clip as well as do other strategies. You said you deploy a flow diverter in MCA as well. So do you do that very often? Which flow diverter do you deploy? Because there are so many branches, so you will cover one of the branches most often or not. So which flow diverter do you use, and why? Like not like a standard or stent like an Atlas stent or just a laser cut stent to support the coils.
I don't have a lot of experience to put the flow diverter, for example, the M-share aneurysm. So recently, but flow diverter, there are some reports the flow diverter is effective for an MCA because the flow diverter effect and flow geometrical modification straightening the MCA, so is effective for aneurysm occlusion. So we try to put the flow diverter, so MCA aneurysm, so because it's the very simple way to treat the bifurcation aneurysm. It's the viable option for these aneurysms.
And you're not worried about the branches which can get occluded, the side branches, because for MCA they are usually there will be some other branches. Your experience, it does not happen.
Yes, I don't have experience to occlude symptomatic occlusion of the side branch. So gradually, I have experience gradually narrowing the side branch covered the flow diverter. It is a high effectively to occlude the aneurysm, I think.
Yeah, it happens over the period of time. That's what you're saying. Yes, that happens. And so thank you so much for that particular portion. And I see you have shown very nice ways to deploy a web in offset aneurysms and what are the techniques, especially the use of balloon. Which catheter you use to deploy the web? Is it the VIA catheter?
Yes, in Japan we use only the VIA 21 microcatheter, and the next spring we can use the VIA 17. So VIA 17 catheter. So I'm looking forward to using the VIA 17.
Yeah, so for young neurosurgeons, again, the VIA 17 is a finer and less bulkier catheter. So it's easy to go into the aneurysms when you're deploying the web device. And VIA 21 is a more stiffer and more wider catheter. So it depends on what size of web you are deploying. But here we obviously use most of VIA 17 catheter just because it's less stiff and it can shape into the aneurysm very well. But yeah, so that this is about the technical component. Do you prep them with dual antiplatelets before, just in case if you have to deploy a stent and if the web comes very close to the patent artery? Have you ever used a stent as a rescue option?
Yes, I have. I have 20% within 20% stent rescue stent we use. So if the web protruded the 50% of to the parent artery, so we use the stent, put the stent to rescue.
So you prepare every patient with dual antiplatelet therapy, like
Yes.
going?
Yes, before mandatory, we use the dual interpreter therapy. After we can treat the simple web. After that, the single interpreter therapy on keep about 1 month.
And then stop everything afterwards.
Yes, yes.
So you stop immediately the one of the antiplatelets, continue single antiplatelet for 1 month, and then after 1 month stop that as well. So no antiplatelets. Okay, yeah, that's one advantage for the web as well. The last question which I'll ask in terms of technical challenges. Do you also shape the microcatheter for aneurysms which are off axis? Do you steam shape them? Because that helps sometimes to move into the, because I've seen some of your PCOM aneurysms or carotid cave aneurysms were almost 90 degrees. So we will actually never treat them with rep because it's like a very difficult angulation. But we have used steam shape of the catheter. Do you use steam to shape the catheter?
Yes, steam shape. Yes, we use the steam shape microcatheter. So we use the experience of the simple coil embolization or toward these aneurysm. We use the J shape. We create the J shape for ICPC and spiral shape for IC cable aneurysm. We often use the made the catheter shape.
With the steam. Okay, yeah, that's a great tip. And lastly, like how many of these webs you have deployed in ruptured versus unruptured? Like how comfortable you are to basically push and open that device in a ruptured setting? So what is your ratio? Like how many unruptured, how many ruptured in all the so many cases, 100 something cases you have shown?
Maybe 20% is ruptured cases. So 80% is unruptured cases.
Yeah, that is that's a key point which I think anyone who wants to do it in future to know. Is like when you start with an unruptured aneurysm because you have a less chance of perforation when you are trying to deploy it. Ruptured comes with experience, and only in selected cases, you can do a web deployment in ruptured. And those who have done many web device placements, they can actually now they are mainly doing it in ruptured situation. But to start with, it's always better to use in unruptured situations. So because you have a little bit of a leeway that the wall will not perforate through if you are trying to move within the sac of the aneurysm. So thank you so much, Professor Tanabe. It was an extremely good lecture. I think I learned a lot as well, especially the use of the balloon and how we can use it to get into the offset or odd angles in ICPC aneurysm. So that was really good. I just wanted to ask if anyone else has any questions in the panel.
Yes, of course. Dr. Liu, any comments from you?
Yeah, thanks, Prof. Tanabe, for a very nice lecture. I probably have two questions, Professor. You showed that incomplete occlusion is about 10%. Does this 10% include cases that you purposely leave occluded? For example, you show some special shape like socks, plate shape, or heart shape. There are certain part of the aneurysm, especially the distal part, you purposely don't put a web in it. So does the 10% include those cases or not include those cases? Because in coiling, we try to pack as much as possible. My second question, Professor, out of this 10%, how many patients over the time that you think you have experienced need retreatment? And what are the options for retreatment? Thank you, Professor.
Thank you very much for your question. So the retreatment rate is about 1%. We experienced the 3 cases of the retreatment. It depends on the recurrent type which we choose the treatment option. One case is one case we treat the coil embolization, additional coil embolization, and one case the flow divert and with adjunctive coil, and one case is the only flow divert, web, additional web and flow divert. So it depends on the recurrent type of the aneurysm. So first question, what is the first question?
Yeah, because you show that your occlusion rate is about 90%.
Mm-hmm.
So I wish to know that does the 10% in incomplete occlusion, including those cases you purposely leave it unoccluded completely? Because you show some cases, you don't occlude completely because of the web doesn't shape accordingly. So are those cases included in the 10% mean your actual incomplete occlusion are lower than 10%?
Sorry. So well, this including the web into the how can I say the web contrast medium into the web is included in the incomplete occlusion. So this is a very benign type. There is a very low risk of rupture. So we need to. There are few cases to treat the retreatment. So including incomplete occlusion.
I mean, maybe the other way to ask this question is you may have 10% of incomplete occlusion during the immediate treatment. When you follow up with 3 months angiogram, would this incomplete now get completed? How many of them will be shown there's no contrast flow within it?
Sorry.
Yeah.
So what Dr. Liu is asking, Professor, is like if, for example, some part of the neck is remaining when it's not completely occluded, in follow-up, do you see those also getting occluded in future? Or it stays like that?
Yes, yes. If the neck remnant can be seen, but this space is still remnant after over time. But if the web contrast medium into the web will be occluded over time, so basically the occlusion rate was increase over time from 3 months to 1 year.
Thank you.
Yeah.
Thank you very much.
Thank you.
So it happens, it closes with time, but at the same time, if there is a neck remnant which is between the main artery and the proximal part of the web, that's a neck remnant which will always be staying, because distal to the web device, obviously everything will close, but proximal, for example, the web is deployed in such a way that there is a small neck remnant because of the angulation or anything like that. That will not get closed properly, because that will be, there's nothing there to close it because the web is distal to that. So any proximal neck which is remaining will stay. But then the argument is like, for all the coilings which we do, for all the other things which we do, we always leave some neck, because you don't want the coils to come very close as compared to clipping. That's the only thing where you don't leave a neck at all. But in endovascular world, you always leave a neck when you are coiling a simple aneurysm, because you don't want it to come into the proximal, into the parent artery. So the web is as good as that. So the counter to that argument always from interventional world is like, you're always leaving a small neck anyways, so that neck remains and it stays stable for a long time.
Thank you.
Well, thank you. I would like to ask one question to Jun. Jun, in one case you showed there was an intraoperative rupture. So how did you manage it?
The key point for hemostasis about intraoperative rupture is to deploy the web immediately. After that, so balloon inflation was inflated to hemostasis. So, but it is important. Most important thing is the immediate redeployment of the web.
Okay, so you did not put a stent after that?
No, I don't have experience, so I think I don't need.
Right. Well, our second speaker, Professor Shi Huaizhang, is a master of neurointervention. Prof. Shi Huaizhang, we would like to hear your comments about web treatment.
Yes, I think the web is very useful for the application aneurysm, and I think if the web I think it's much better the operation rather than the flow dilator for the application aneurysm. I think I learned a lot of things from the Professor Tanabe presentation, especially for the blue assess and wipe. I think it's very useful. The blue, I never try it. Maybe in the future, I will try it. Thank you very much. Thank you very much. I have a question. Yes, because if the wipe, the position is not very good, some part of the wipe intrude the parent arteriole. You said you will deploy the stent. You will deploy stent, but I think the wipe is much stiff than the coil. So if the wipe intrude the parent arterioles much than the 60 or 70%, do you worry about concern the stent can open totally?
Thank you for your question. The stent, we use the neuroform atlas. So neuroform atlas always expanded the against the web, so we can get the parent artery diameter with the stent. So we don't have experience to web protruded remained after the stenting. So yes.
So will you leave the stent in the parent arteriole, or after you adjust the wipes the position, after that you take the stent out?
I usually leave this stent parent artery. Yes.
Okay, thank you.
Thank you,
Prof.
Dr.
Ashish, for his final remarks.
Yes, I just wanted to add to that because this is a very interesting discussion. I think the pre-op planning, which was shown before, is very important to foresee what's going to happen. So the sizes are made based on what is the width of the aneurysm sac, and that's the most important, not the height, because we are not even going up to the complete height of the aneurysm. If you are compressed side to side, there will be no flow going distal. So that's why the width is very important. And if you are before you detach it, you see how much is coming out. If we see that it is more than 60%, then you have a wrong size. So you basically do not deploy, pull it out, take another one, and then get the calculation right, and then go there. So that's usually, if it is 60 to 70% of protrusion, means there is something wrong in size calculation. So that's what happens usually is there is a very small edge which comes into the main artery, around 20%, or maybe not even 30%, maybe something 20 to 30% max will come into the main artery, and their stent can easily open. I think if this was also your question, because if it is more than 50%, that means there is something wrong in choosing the size. So you don't detach it. You just take the whole thing out, because the good thing with the web is if it's not detached, you can unsheath again and come back with a new one, and then make new measurements and then probably work around it. So well, thank you so much, everyone. It was an excellent discussion also on this device, which is rapidly catching up in neuroendovascular world. I would like to thank Professor Tanabe, Dr. Shi, Professor Liu, Professor Raja for engaging in such a rich discussion. So again, thank you so much, and I would like to hand it over to Professor Raja.
Thank you very much. It was indeed a very wonderful presentation. Thank you, Professor Dr. Jun Tanabe, for this wonderful presentation, and thank you, Ashish, for coming in. So I'd like to mention that this webinar is being broadcasted on WeChat, YouTube, and Zoom, and as of now we have around 930 people who have logged in through different channels. We're extremely grateful to Prof. Shubin for broadcasting this on the WeChat channel. Now we move on to the second session. If Dr. Jun or Prof. Ashish would stay back, it would be wonderful to have you, but you are free to leave as you wish. So I'll hand this podium over to our very honorable Professor Hidehito Kimura to carry on with the second session.
Thank you, Rajab. I also enjoyed Professor Tanabe's lecture. So I understand so many things about the treatment of the endovascular treatment from the current strategy using the web. Yeah, so interesting. So in the current, as I mentioned in the vascular era, the treatment of the strategy of the cerebral aneurysm shifted to endovascular treatment. So I understood mainly or almost all. Maybe almost all aneurysm can be treated by the endovascular treatment, first treatment option, I understand. So next, Professor Shi will talk about the microsurgical treatment of the aneurysm in the intervention era. So after Tanabe's lecture, I learned and looking forward to hearing your lecture. Thank you. Please start your lecture when you're ready. Thank you.
Thank you.
Thank you.
Thank you. Thank you for the invitation for me to this presentation. In this presentation, I will introduce my experience of the microsurgical treatment of the aneurysm. I think like the other centers, in my center, the most aneurysm was treated using endovascular methods. This is my personal data last year. Last year, I treated more than 1,000 aneurysm cases using the interventional method, but I still treated about 100 aneurysm cases using the open surgery. So as an interventional neurosurgeon, why do I insist on the microsurgical treatment for the aneurysm? And when will I choose the microsurgical treatment for the aneurysm? Basically, I think, in my opinion, all aneurysm with a high interventional risk or lower interventional efficiency, I think for such aneurysm, I will perform the microsurgical treatment. I summarize the following several types of the aneurysm. I will treat it using the microsurgical treatment. The first one is the ruptured aneurysm with a hematoma. This MCA aneurysm and with a large hematoma in the temporal lobe. And during the operation, I evacuate the hematoma and clip the aneurysm and remove the bone flap in the same stage. So this is the CT follow-up 1 day post the operation. The patient recovered well. So I think it's a good operation using the open surgery for this case. And the second situation I will choose the open surgery is for the complex MCA aneurysm. For this aneurysm, it's a very wide neck aneurysm and very complex. Which way is the best way to treat it? The wipe, the flow dilator, or stent-assisted coiling? I think neither of them was a good operation. So, but if we choose the open surgery, I can perform the combined clipping with multiple aneurysm clips and direct vision. I think this way we ensure there is no aneurysm residue and all the parent arterial patent. Just as shown in the schematic diagram on the right. This is the screenshot during the operation. I used 5 clips to clip the aneurysm. This is a similar aneurysm, the similar aneurysm, MCA wide neck aneurysm. I adopt the same strategy to perform the combined clipping with the multiple aneurysm. So before I clip the aneurysm, I using the 3 temporal clips, clip the M1 and both M2. This method this can reduce the tension of the aneurysm sac, facilitating the clipping. So after that, I use the 1 aneurysm clip to clip the aneurysm sac, which can reduce the volume of the aneurysm. This free up the more space for observation, avoid damaging the apparatus, and facilitate accurate clipping with the subsequent aneurysm clips. And after clips the aneurysm body and reduce the aneurysm volume and clarifying the overall relationship between the aneurysm and the parent arteriole, I can place the aneurysm clip parallel the parent arteriole and shape it at the aneurysm neck to avoid the Doppler's end. And the ICG showed all the parent arteriole is patent and there's no aneurysm residue. And I'm sorry. And the DSA follow-up showed a good result, as if there's no aneurysm excited. This is the clip. Next one is supraclinoid segment aneurysm. But I don't think not all aneurysm in this location are suitable for open surgery. But if they have the following 3 characteristics, I tend to perform the surgery. The first one is the size. It's a big one, bigger than the 10 millimeter. And the second one is the narrow neck, very narrow neck. And the third one is the direction is pointing upward. Because for aneurysm with these characteristics, whether we use the double flow dilator or flow dilator assisted coiling in embolization, there's a relatively high bleeding rate post the operation. It's reported about 8% aneurysm will bleeding post the operation. Each bleeding means the disaster result. And the second reason for this because it's a relatively large size and the upside and upwards the direction, such aneurysm often compress the optic nerve and will affect the patient's visual field. So if interventional surgery is performed, it's not quickly relieve the compression to the optic nerve and restore the vision in a short time. But if we clip it, I think it's much better than the embolization. And the third one I will try to clip is because the narrow neck means that it's very easy for clipping. This is the one case. It's the narrow neck and big sides and point upward. This one aneurysm. For this aneurysm, I clip it using only one clip. It's not very difficult. This DSA results post operation. And this is the 3D. The aneurysm and the clip. The second aneurysm case is similar from the MRI and MRA and DSA. We can find the aneurysm at the supraclinoid. It's the DSA I after open the segment fissure, we can expose the aneurysm, the big aneurysm. The aneurysm sac is adherent to the frontal lobe and compress the optic nerve severely. This is adherent to the frontal lobe. It's the aneurysm, a big size. This is the second nerve. And I resecute the anterior clinoid process. It's very important. It's a key point for clip the such aneurysm. And after that, clearly incise the distal ring and expose the aneurysm neck. This is distal one. This is the second nerve, optic nerve, and this is the aneurysm neck. It's a distal neck. I placed one clip. After the first clip, we can make the more space to observe the arteriole, the ICA, and the aneurysm. I placed one more clip. After that, I take the ICG examination. The ICG showed the ICA is patent, and there is no contrast in the aneurysm. It seems good result. But when I puncture the aneurysm, I want to make the volume smaller. I found that there's still bleeding. So for the safety, I placed more clip, straight clip, and the other shape clip. This is the final result. This is the CT scan post 1 day post operation, and the DSA showed the parent arteriole is no stenosis and the aneurysm disappear. It's the CTA. This is a clip and the arteriole. There's a small aneurysm in the I will leave it alone because it's not in the cranium. So the next one is the anterior caudal arterial aneurysm. For the anterior caudal arterial aneurysm, usually is tiny aneurysm, but the anterior caudal artery is small. It's very small. So in my experience, some case during the operation is good, but maybe several days, 1 week after operation, one month after operation, the patient suddenly hemiplegia. It means the anterior caudal arteriole occluded. So how to preserve the very important arteriole is a key point. But for the embolization, I have no confidence to preserve all the patients this arteriole. But if we treat it using the open surgery, it's very easy because the aneurysm is a tiny aneurysm, and after we temporarily clip the ICA, it's very easy to clip it, just as this map showed. I clip the aneurysm parallel to the arteriole. This is the screenshot during the operation. This is the ICG result during the operation. It showed a good result. This is the DSA examination post operation. So For this case, I think it's very safe, much safer than the embolization. Next one is the multiple aneurysm. It's not it's usually we can see multiple aneurysm. For this case, there are two aneurysm as the MCA bifurcation, and there's a tiny aneurysm at A1. Here is A1. So I think it's no way to embolization the tiny aneurysm as A1, and it's not easy to embolization these two aneurysm, even using the stent assisted choline or maybe flow diverter. But I don't think it's a good operation. But for the open surgery, we clipped all the three aneurysm at same operation. It's not difficult. This is another case. It's 5 aneurysm in the same patient. I clipped all the 5 aneurysm at the same time. For the left side is MCA aneurysm, small one, and the A1 aneurysm. For the left one is a complex, the wide neck MCA bifurcation aneurysm, and there is ophthalmic aneurysm, and in the middle line is ACOM aneurysm here. So I treated from the left side. This is the before operation. It's the post operation. I clipped all the 5 aneurysm. This is the left side. This is the post operation. It's the before operation. Both the two aneurysm disappear. And the left side, this is before operation. It's the post operation. The MCA aneurysm, the ophthalmic aneurysm, and the ACOM aneurysm. All the 3 aneurysm was clipped totally. I think for the multiple aneurysm, the open surgery is much better than the amputation, I think. And in some cases, the aneurysm combined with the other lesion. For this case, it's a mini-droma and the ACOM aneurysm. So I rescue the mini-droma at first. And after that, the aneurysm I clip it. It's A1 and both A2. The first clip, and there's more aneurysm rescue using a mini clip to clip it. That's all. So, and the other case is the M1 severely stenosis, and there's 2 aneurysm as the PCOM and the MCA bifurcation. So for this case, I performed the bypass at first, STA to and the M2. After ICG confirmed the bypass vessel artery is parent. After that, I clipped both the 2 aneurysm. So I treated the patient in the same operation. And the next one is the aneurysm recurrent after the interventional surgery. This is the case of the rebleeding after standard assisted embolization. It's MCA. The first embolization, the physician placed a stent from the M1 to the M2, the superior branch. But this time, the DSA result showed that the aneurysm is at the inferior branch. So if we treated the aneurysm using the interventional method, I have to navigate the microcatheter, the standard microcatheter, and the manifest through the cell of the first stent. So it's not very easy. But if I clip it, I think maybe it's much safer than the embolization. So during the operation, I found the aneurysm is a tiny aneurysm, and the aneurysm wall is very thin, just like a blissed aneurysm. And this is the coin, and this is the stand. So I first placed a small piece of cotton on the aneurysm wall to increase the friction. And after that, I clipped it with a aneurysm clip parallel to the infra branch, and I see there's the stand. We can see the stand ICG, and the parent artery is the patent. It's a good result. So the last type of the aneurysm I prefer to the open surgery is some aneurysm I have to using the bypass. For this case, this is a very tough case. From CT scan, I found a giant thrombosis aneurysm with a small amount of the hemorrhage in the temporal lobe, and there's some infection at the temporal lobe here. The MRI showed the thrombosis, the aneurysm, and this infection here. This DSA showed it's a huge M1 dissection aneurysm with a huge thrombosis, and there's a bifurcation in the MCA bifurcation is a circular aneurysm, small circular aneurysm here. So for this case, I think the bypass is the only solution. Only solution, I think. So I adopt the strategy just as shown in this schematic, the diagram. The first one, I should high flow bypass from the ECA to radial arterial and to the M2 supra branch. Is first, and the second one, second step, I will clip the small aneurysm in the bifurcation, MCA bifurcation, and the third one, I will tripping the huge the thrombosis aneurysm in the M1, but I should preserve the lenticular lacerate arterioles. This is the operation. I perform this operation by the left terminal approach, and I also expose the left ECA in the neck, and I also the radial arterioles was harvested as the graft. During the operation, this is a small circular aneurysm, aneurysm, and at the first stage, there's the radial arterial. The bypass was performed at first, and from ICG, I confirmed the bypassed arterial is the patent. After that, I took the aneurysm, small aneurysm, and incised the big aneurysm. After resecting the entire aneurysm and the small bosses inside it, we can find the M1 This is the M1. I place the 2 clip to trapping the big aneurysm. The HG showed the very good result. The bypass artery is patent. The CT scan 1 day post operation showed there's no more infection and the patient has a good prognosis. The next case is the PICA dissection aneurysm. For this case, I think the maybe flow diameter is okay, but because the PICA is very small, it's small arteries, so it's not easy to navigate the microcatheter to the distal part. So I think maybe the bypass and trapping is a good option. So at first I performed the bypass surgery between the occipital arteriole and the occipital arteriole and to the PICA distal segment of the PICA, and after that I will place the a clip between the aneurysm and the perforator, occlude all the PICA and the aneurysm, but preserve the perforator. I adopt the retrosigmoid approach to do this operation and dissect the occipital arteriole, and you post the aneurysm. This is the aneurysm, big aneurysm, and the PICA and the vertebral artery here. And I also dissect this distal to the aneurysm, this PICA. I perform the bypass from the occipital arteriole to here. It's the bypass progress. This after the bypass surgery. After from the ICA, after confirm the bypass artery is patent, I using a clip occlude the PICA and between the aneurysm and the perforator, and the ICG confirmed the good result. This the DSA examination post-operation. This is the AP view and the lateral view showed the aneurysm disappeared and the perforator is preserved, and the occipital artery, the bypass artery is patent. The CT post-operation showed there is thrombosis in the aneurysm. The patient recovered well. The last case is the ICSC bypassed. This dissection aneurysm as the M2. For this case, I tripping the dissection aneurysm and perform the bypass, the side-to-side bypass. It's the infra branch, is the super branch here. This is the screenshot during the operation, tripping the aneurysm and this side-to-side bypass. This is the CT scan 1 day after the operation, showed no infection, and the 3D is the side-to-side bypass the location. And this DSA examination showed the flow direction from this one from the M1 to the infra branch and to the bypass and to the super branch. So I think, in summary, I think interventional treatment like the light weapon that can solve, I think, solve most problem, most aneurysm. We can treat it using the interventional treatment. But for some difficult case, as I showed before, I think microsurgical operation is equivalent to the heavy weapon. It can serve as an excellent supplement for this kind of the aneurysm. And for the most difficult aneurysm, I think the bypass is like the nuclear method. It can, I think, bypass and tripping or bypass and occlude the parent arterial is the final, it's the ultimate solution to this difficult case. So for the neurosurgeon, we should have the ability to treat the aneurysm, use all the three methods. That's all. Thank you. This is our team. Thank you.
Thank you, Professor Shi. Fantastic. So fantastic lecture. You mentioned about several kinds of cases needed for the direct open surgery for the treatment of the cerebral aneurysm. I was so impressed. I enjoyed your lecture. I learned a lot from your lecture. Thank you. So you talked about several aneurysm, especially with the patient with a hematoma with a ruptured case and a complex MCA aneurysm. And after that, you talked about the supracrinoid segment aneurysm, and following the anterior caudal artery aneurysm and multiple aneurysm with another kind of pathology, and also the aneurysm recurrent after the coiling. And finally, you mentioned about the bypass cases needed for the treatment. But I totally agree with your concept, and I do in my university hospital say same technique and the same strategy for especially for the several kind of complex cases treating by complex cases is in the endovascular area. So maybe you talked about you show the cases maybe very difficult for the endovascular treatment cases. So my first question is I have several questions, so thank you.
Okay.
So for the cases with supracranial segment aneurysm can be treated easily by direct surgery. I agree with your comment. And do you use a suction decompression technique for the use large aneurysm, supracranial aneurysm? Thank you.
Yes, yes, I think it's very important. Yes, for the two cases, both the two cases are using the section. For all both the cases, I expose the ICA at the neck, and after we expose the aneurysm, the tension is very high. It's very high. So and there's no space there's no chance to temporal occlude the ICA at the ICA before the aneurysm. So the only solution is the temporal clip the ICA at neck, and after that I clip using the temporal clip as the A1 and M1, and after that I will maybe you can puncture the aneurysm, and
decompression.
sucks bleeding. Yeah, yes, and using this way, we can make the more space, and to see the neck, to observation the neck. So I think it's very important. But I think maybe next for a few cases using the BGC balloon guiding. Balloon guiding is in the hybrid operation room. Yes, and after you inflate the balloon and suck the suction from the BGC, it's the same function, I think. Yeah.
Yeah, thank you for your comment. So I recommended to use the suction decompression technique for the especially for the large paracranial aneurysm for the safe. So when you use that suction decompression technique, so paracranial aneurysm much easier to be treated. So with so safe. So, but in my experience, we use a suction decompression technique by decompress using the superior thyroid artery. And in Japan, Professor Tanikawa mentioned about it, so we use a suction. Yeah, it's maybe the surgery much easier to do so. So just so I recommend younger neurosurgeon to do the suction decompression when you treat the direct surgery for the paracranial aneurysm. So that's one comment. Yeah.
Thank you.
And so do you another question? So have you experienced the visual disturbance or post-operatively with the case of the paracranial aneurysm? Maybe it's a great matter post-operative visual impairment of the paracranial aneurysm but when a patient treated with direct surgery. Have you ever experienced such kind of this post-operative complication, visual impairment?
You mean the bypass case?
No, sorry, paracranial aneurysm.
Yeah.
Yeah. Thank you. So maybe we sometimes encounter the post-operative visual impairment, visual disturbance after the surgery. No,
no.
Maybe great matter
yes.
for the surgery. Yes, yeah, for the direct surgery. Okay.
Yes.
So my next question is so we direct surgeon vascular neurosurgeon have to learn the techniques of the several kinds of bypass technique as you mentioned. So especially for the selection for the revascularization for the pica, sometimes we use the OA pica as mentioned in the presentation, but sometimes we can choose the pica bypass.
Yes.
I think the pica bypass is much easier, much safer to select the OA pica bypass because the OA might be occluded post-operatively. Occipital artery may be easily occluded post-operatively, I think, from my experience. So recently I tend to use the pica bypass, maybe much better for in terms of the rest invasive surgery, maybe pica bypass may be better for me, I think. How do you think about it?
Yes, well, for this case, the pica aneurysm dissection aneurysm case, it's the left side pica, but the right side pica, there's no right pica, only the left pica. Yeah, so there's so no way to do the pica.
Thank you. Yeah. Do you select some other patient to use the pica bypass? Do you have some experiences?
No, I have never tried. Maybe next time.
Yeah. Oh, okay, thank you.
Yeah, thank you.
Thank you.
Yeah.
And one more additional question. So, how do you select the patient when you perform the high flow bypass? How do you select the graft using the which graft, saphenous vein graft or radial artery graft? Which your preference to use as a graft?
I prefer the radial artery. I think the maybe is much better than the others. Yes.
So, why do you use that radial artery? So one more time, please.
Yeah,
I
yes.
I like to use a saphenous vein graft actually because
Really. What about the long-term the follow-up? I'm concerned about the long-term the follow-up
uh,
because the vein is not as the better as the arterial.
yeah,
I
I
think.
agree.
Yeah.
But yes, my patient needs antiplatelet drug as subtu. Single antiplatelet drug may be needed post-operatively for you when a patient use saphenous vein graft. The
Right.
radial artery graft no need to use antiplatelet drug. I think so. Yeah, but sometimes radial artery graft may be limited length of the to
Yes.
be harvested. So
Yeah.
I have a so I just concerning about the adequate length of the bypass graft. So I asked the cardiologist to harvest the saphenous vein graft first. That's my comment. But yes, I agree that radial artery may be better for the arterial graft. Yes, thank you.
Yes. Yes, I have been to the Professor Tanikawa's centers and to see the 1 week's course. Yes,
Oh yeah,
yes, it's
yeah.
fantastic. It's good.
Great.
Yes,
Yes, thank
yes.
you for your great
It's
comment.
7 years, 7 years ago. Yeah, 7 years ago.
Yeah,
Yes,
yeah. In June. Yeah, July. Yes. Yeah. Thank
yes,
you.
yes.
Thank you.
Excellent.
Yes.
Thank you.
Thank you.
It's my question. So I will just hand over the Raja. Thank you. Continue
Thank
to
you.
your
Thank you
question.
very much
Thank
for
you.
this very exciting lecture, Professor Shi Huaizhang and chairing Professor Hidehito Kumura. One question that I would like to put across to you that in the first case you showed about MCA aneurysm, you took out both the M2s as well as the M1 for the bypass. Okay, so what is your occlusion time in such cases?
Yeah, yes, because after the bypass, after the high flow bypass, I think the trapping the thrombosis, the big huge aneurysm. I think for the M2 and M3, I think the flow, the blood flow is enough, and uh, and the huge aneurysm from the M1 to the M2. I think there's no perforator, so there's no perforator, so I decide to trepan it. Yeah.
Right. Thank you. Thank you very much. One question to Prof. Kimura is that you told that Paika is easier to do. I understand because both are very close. But the problem there is that if something happens, both sides are gone. So that is why, for safety reasons, people choose the OA Paika bypass.
Yes, next time I will try. I will try. Yeah.
So thank you very much for this. Jun, would you like to say something?
Yes, thank you for your excellent lecture. This aneurysm you showed very difficult to treat by web or for diabetes. So direct surgery keep essential technique for these aneurysms. So I have a question. Direct surgery required high technical skills and a lot of experience. How do you educate the young neurosurgeon to become direct surgeon like you?
Yes, it's a good question. In my centers, because Harbin Medical University is located in Harbin, it's northeast China, so there's a lot of the aneurysm case, and for the MCA aneurysm, for example, for some MCA aneurysm case, we can choose the embolization, or we can choose the clipping. So, but for some to educate the young generation, in some cases, I will choose the clipping. Yeah, yes. So I think we should maintain some clipping case, the open surgery cases to let me and let the young generation to have the ability to handle this situation. Because for some difficult cases, like I show you before, maybe open surgery is much better than the embolization. So in this case, if we have no ability to open surgery, so it's very difficult and very dangerous. Yeah.
Thank you. Another question is about the anterocoroidal artery aneurysm. So, anterocoroidal artery aneurysm can be it is difficult to do the neck creeping for neck to do the neck creeping. So because the anterocoroidal artery often originated from the aneurysm dome, so I sometimes can't do the neck creeping. How often can you creep the do the neck creeping?
Yes, yes, it's a good question. I think if the anterocoroidal arterial raised from the aneurysm, I think for such case, if we treat it using stent assist coordinate, it's very dangerous. I think maybe we have no confidence to preserve the arterioles. Yes, but for the open surgery, because we just under the veil, direct under the veil, so we can observe the aneurysm and the arteriole, and the ICA and the anterior caudal arteriole. So I like to use to clip the aneurysm parallel to the anterior caudal arteriole. So I think it's much safer. Yeah, parallel the anterior caudal arteriole. Yeah.
How about flow diverter for anterocoroidal artery aneurysm?
Yes, maybe I think it's a good option, but for the ruptured aneurysm, I don't think it's safe. Maybe unruptured aneurysm, the flow diverter is okay.
Thank you very much.
Thank you.
Thank you.
Any comments from Ashish?
I would just say, like for anticoroidal, if it's ruptured, sometimes we use balloon techniques to simple coil it, to keep some coils and just wait for 4 weeks for the blood to get absorbed, and then deploy a flow diverter, just like interval, like stage treatment. But as I said, excellent presentation, as everyone said, Professor Shi. I like the picture at the end, like the machine gun, the tank, and the bomb in terms of intervention. Fast, but it was pretty good in my opinion. I just have one question. The supraclinoid ICA you clip, and that's traditional world that will be treated with a flow diverter. So just wanted to know, like I know you said because of the compression of the optic nerves, but for compression of optic nerves also, like there are studies which has shown that the visual acuity over the period of time will also improve with a flow diverter as well. And if it's a big aneurysm, you just put some loose coils into it to prevent rapid thrombosis. But otherwise, as soon as the flow pulsations come down, the visual acuity actually improves. But of course, surgical treatment will bring it very quickly, like improve the vision very quickly because you're clipping it directly. But flow diverter also works on the long run. So just wanted to know, like because that's a very classical flow diverter treatment for in today's world, the supraclinoid ICA.
Yes.
Okay, thank
So
you.
do you like my question was, do you never do a flow diverter for such cases for supraclinoid?
No. For such case, I use the flow diverter at first for I think maybe more than 50 cases flow diverter for such cases. But I have met the two cases the bleeding post operation. So one died and one the outcome is good. But so after that I use the double flow diverter or flow diverter assisted calling much call Yeah, but I still concerned about the bleeding post operation. So in China, some physician with I do agree with some physicians the suggestion. They put the staged calling at the first operation, just the calling, and after that maybe 1 month or 2 months later, and use the flow diverter to treat the patient again. This the method can reduce the complication of bleeding complication. Yes.
Right.
Okay. Thank you so much.
Thank you very much. So indeed, we had a wonderful presentation from Professor Shi Huaizhang. We learned a lot. Thank you, Prof. Hidehito Kumura, for sharing this session. Now, with that, we come to the end of this webinar, and I would like to close this officially. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato, I would like to thank both the speakers of today, Dr. Jun Tanabe and Professor Shi Huaizhang, as well as Prof. Ashish Kumar and Professor Hidehito Kumura, who were the chairs for this session. And thanks you everybody for the time and support for the ACNS webinars. A very special thanks to Professor Shubin for broadcasting this webinar on the WeChat channel. And as I mentioned earlier, this has been broadcasted on WeChat, YouTube and Zoom. And as of now, we have around 930 people who have logged in through all the different channels. A special thanks to my co-host Liu Bun Singh for joining me today. And with that, we come to the end of today's webinar. I hope to see you all next week again. Thank you very much and bye-bye.